Good evening, everybody. Good evening to all of you from everywhere in the world. I would like to introduce you for this webinar, Dr. Markus Köpert from Germany. He's a specialist in anesthesiology, intensive care medicine, emergency medicine, and palliative care. And he has several subspecializations in ultrasound in anesthesia, transfusion medicine, hospital hygiene, and antibiotic stewardship expert. These webinars provide an overview on the current status and an outlook on future development in regional anesthesia. Please, I just want to recommend you that if you have any question during the webinar, please use the Q&A for your question and not the chat room. And have a nice webinar to all of you. We can start.
So good evening, everybody. It's my pleasure to have this talk today, sponsored by PAJUNK and supported by ESRA. These are my disclosures. As everybody knows, this is a PAJUNK webinar. And the most important conflict of interest I have is that I'm doing a lot of regional anesthesia. I'm a member of a lot of regional anesthesia societies, but they are not paying me, but I'm paying them. This will be a little bit atypical webinar, I think, because I will not present you the details of several blocks, but I will take you on a wild ride, on a furious ride, and a tour de force about all the questions that have recently dropped in regional anesthesia, the current developments, and I'll also have a little glance at the crystal ball, what may happen next. And I will ask you some provocative questions. So, for example, one of these provocative questions is, did ultrasound improve patient safety in regional anesthesia? There's a very good article by Michael Barrington, is one of the most publishing regional anesthesiologists in the world. And I also wrote a little summary about these questions. And we know that ultrasound alone did not change anything. Ultrasound alone does not save our patient. It's not the only tool that provides patient safety. And we know by now that there is not one single tool. So we have to ask another provocative question. Do we need even more blocks? Because we know there are lots of blocks proposed in literature with very low evidence sometimes. Everybody has another approach. So do we need even more blocks, or do we need more safety for the patients? And this is an ongoing discussion. We are discussing that at the moment in the German society. I'm part of a group which is discussing that. But also when you look at MySORA, the group of Professor Hadžić, it's a big issue, a big question that people ask, should we invent more blocks, or should we invent some safety standards that are the same for everybody in every country to prevent damage to patients? And one of the big questions that was raised in 2019 already was the editorial by Professor Turbit. If we really need all these blocks for experts or nerds, or however you want to call us, or if we want to have some basic blocks that every specialist should be able to provide in the same way. And one of the most important questions when we talk about patient safety is wrong-sided blocks. Wrong-sided blocks are defined as a never event. This should never happen that we block the wrong side. The real life is quite different. The reported incidence, and you can be sure that not everything is reported, this is unacceptably high. It's 7.5 per 10,000 events. So this is really a lot. So we have to think about the fact, how are we able to change that and to become safer? One of the possibilities, or in my opinion, the easiest possibility, the easiest way to change that is that we have a stop before you block strategy. We'd have to do a team time out, like we do for the operations, like we do in surgery, questions to ask, and stop a moment, stop before you block. Is it the right patient? Is it the right block for the planned surgery? Are there special contraindications? Is the site and the site of the surgery marked? Is it the same site as the site you want to block? Are there relevant allergies? Are there skin infections? Do you have adequate monitoring established? Is a resuscitation card available? Does the patient need sedation? Do we want to do a single shot or a catheter? Do we have the correct hygiene standards? We will talk about that later. What LA, what volume, what concentration, and so on. So please implement standards. And you can do this, for example, by a sticker you put on an ultrasound machine, or you can use a screensaver. Feedback communication, like in an airplane cockpit, is essential for patient safety. Ask everybody in the team, does everybody in the team feel qualified and familiar with the planned block? Did you ever do that? Did you ever assist that? Does the assistants have the necessary knowledge to operate your sonar machine? You all probably know very well that slight changes in the sonar machine can change your picture completely. Is help or supervision available if you need it? If you are not the most qualified, the most expert in your team, is there somebody you can call to help you? Is everybody aware of potential complications? Do we have a plan B if it doesn't work? Is there a calm atmosphere? Are there defined roles in the team? And then there are some specialist questions that you can ask if you are really an expert. Is the injection done by assistants, or is the provider injecting himself? What we do a lot of times in my clinic, it's for some blocks nearly the standard. This is one picture of my clinic. If it is possible to do it yourself, you will need smaller volume of LA if you use the drop as you go technique. So this is something to think about, but surely not the most essential thing when you start doing blocks. Please take care of the details if you do blocks. That's the most important thing. For example, there are different needle lengths that everybody is aware of, but there are also different echogenic qualities and different needle tips. Nerve blocks and fascia blocks use different needle tips. They are blunter or sharper. So please have a look what your assistant provides to you. What needle do you have on your table? Before you open it, then you can save some money, that you always have the right needle for the right block. The same thing goes for the probe. Do you need a linear or curvilinear probe? The ultrasound preset is important. One very, very stupid thing which happens all the time, again and again, is the battery status. Who of you has never had the situation that you are doing a block and out of a sudden the machine is down because the battery was out? So check that before. What is very important, what I teach to every assistant, to every resident in my clinic, is the one-axis probe eye monitor. Dogma. For me, it's really a dogma. Put the machine in a way that you do not have to turn your head. Have one axis from the probe, your eye, and your monitor. If you turn your head and you are a beginner, you will surely move your hands and you will lose your picture or the position of your needle. This sounds quite basic, but it's very important because that's how mistakes happen. And you can make your life easier if you think of these details. There are very few people who are able to turn the head and to keep the hands calm. And you have to think nowadays, at least in Germany, about documentation of pictures or loops, because it's important for forensic questions and for money. Here's an example of a safety tool that has also commercial potential. And I don't want to talk against this tool, but do not expect industry or somebody else to solve your problems. It is you yourself who has to have a plan, who has to have a structure, and you have to have a clear attitude how you want to provide safety to your patients. And a cover with an attitude, there's a nice YouTube tutorial on that. This is surely nice to have. And it's nice to have a stop sign on the cover. But there's no trial, no evidence that this saves your patient. This is only a piece of the puzzle. And you have to implement structural safety features like a team timeout. If the patient is awake, include the patient in the team timeout, ask the patient, look for a clear marking of the site, and use cross-checking between your own chart and a surgical chart. This is also important that the same site is marked in the anesthesia chart and in a surgical chart, so you can use that. And this is surely more important than to have what happened now? Sorry. I lost the picture, but we will come back to that. Okay, there we are again. So it's important that you have your structures and not rely on a tool. As we're talking about probe covers, sterile probe covers are safety tools to prevent infections. I think everybody agrees on that. And there's a very nice article by the group of Professor Hadžić, a good review about the importance of these covers to prevent infections. Another important thing is that the ultrasound gel has been identified as the source of outbreaks of multi-drug resistant bacteria. Ultrasound probes also have been identified as the sort of outbreaks of multi-drug resistant bacteria, because not everybody is always cleaning the probe very well after using it. So in single shot, the covers present to touch the probe with a needle. In catheters, we have the same rules as, for example, for a central line. So in catheters, you should use anyway long covers which are covering the whole cable of the ultrasound probe. You have to wear a surgical gown and so on. So this is about hygiene precautions. There is some data from UK or some evidence from UK how to use sterile jelly inside the cover. Okay, everybody of us knows that our gowns are not always perfect. They sometimes have small holes. The same goes for the ultrasound covers. So you should use sterile gel inside the cover. And on the right side of the slide, I showed you a small overview about the studies or the case reports of ultrasound gel related transmission of outbreaks in a hospital. Not an infection in your single patient, but an outbreak in a hospital with nice animals like Burkholderia and things like that. You don't want to have that, and you don't want to have an outbreak. So ultrasound gel is really, really dangerous for infections, and so you should use single-use sterile gel. How do you use sterile gel safely? You should never puncture through gel, never. Because even sterile gel can cause neuritis and arachnoiditis. We know that from neuraxial anesthesia. And you should neither puncture through lakes of alcohol, octinidine, or chlorhexidine. You should disinfect. You should wait till it dries, because there's a time-dependent efficacy of disinfectants. And after it has become dry, then you should use sterile saline for coupling your probe to the patient. Not alcohol, not jelly. The limitation is that there are nearly no RCTs. These are expert opinions. These are case reports and different guidelines from different countries. But I do not see how we should run a trial on that. I don't want to be the patient in this trial. Yeah, so I think safety first, patient safety is always the most important thing. And so we should do it like that. We should use sterile covers. We should use sterile gel inside and sterile saline outside, and not puncture through gel and through alcohol or chlorhexidine. This is dangerous. So I had this talk ready. The lecture was finished. And then I went to Munich, to ESRA, Euroanesthesia, and somebody presented this paper. It's a very recent paper from 24. And they questioned the cost of sterility and argued, the authors argued, that we should not mandate for single-shot peripheral blocks to use a sterile cover. They argue about costs. They argue about availability in different countries. It's not the same everywhere. They argue about environmental impact because, okay, it's trash at the end of the day. And they discuss about sterile procedures versus clean techniques. I argue against their paper. Just go tomorrow to your OR and look to yourself and look to your residents and look at your boss, because the boss is mostly the guy who has the least time. And how clean is a clean technique? How clean are people working in their daily practice? Are they really away from the probe with their needle? Do they really clean the probe after using it? Do they really use sterile gel, and so on? So in my opinion, patient safety is primordial, it's crucial, and we should use patient safety anyway as good as we can. And please keep in mind that several of the most popular modern blocks are very close to the surgical field. Think of TAP block, think of PAJUNK block. You are very close to the surgical field. So, okay, I listened to that talk, I read the paper, and I tell you, in my opinion, this is an opinion paper. This is not real evidence. And we have to keep in mind that the absence of evidence is not the evidence of absence. So my choice is to use these covers for single shot, the short one, sono cover, for catheter placements, the long one. An alternative is to use covers with some glue, some adhesive structure on it. Then you do not use gel, you have the adhesive structure on your probe. But keep in mind that physically, this adhesive, this glue, may attenuate your ultrasound beam energy. So in plain English, your picture may get worse. And only use certified products. Don't use what we did back in the days, Tegaderm and things like that, because my company, which provides my ultrasound machines, they told me that, that if I use non-certified adhesive products, then this may damage my probe and I may lose my warranty, and I do not have the money to do that. Another topic, I told you, we will go on a wild ride. Preventing last. How must we prevent last? Safety standards and standard operation procedures are mandatory to prevent last. Does everybody in your clinic know where your lipid solution is stored? Go to your clinic tomorrow, ask everybody, ask every specialist, every resident, every nurse, if they know it. Everybody normally knows where dantrolene is stored, but do the same thing as for dantrolene for your lipid solution. You need signs and marks like this from my clinic. You can have industrial solutions that help you. You have to check regularly, is there sufficient stock, is it not expired? And you have to implement a routine control with checklists. You have to have a resuscitation card available, and you have to think, I don't have it in my hospital, but if you have the opportunity, think in the cases of last about mechanical circulatory support, because you have to do prolonged CPR, so eCPR with ECMO, things like that. If you have it in your hospital, it's nice to think about it. To prevent last, have an SOP at your ultrasound machines. In my clinic, everything is digitalized. We have everything on computers, on handhelds, and on iPads, whatever. But these things are to read at the ultrasound machine. There are the clinical signs of a last, how to detect it, and there is a sheet on the ultrasound machine where you can look if your patient is 50, 60, 70 kilograms, how much do we have to give in milliliters. So keep it simple, because in the moment of an emergency, nobody wants to open a computer and to look for something that is digitalized somewhere. So please have that really at hand. This is really important and can be life-saving. And the most important thing to save lives, to prevent last nowadays, is NRFit. We saw the little film about NRFit at the beginning of the webinar. I know the guys who were in the commission to develop NRFit in Germany, and it should have become mandatory. It should have become mandatory in 2016, 8 years ago. And from the data I could get at the moment, 8 years later, 20% of German hospitals are using NRFit. This is a disaster for patient safety. Why is that? You see this picture from my clinic. This is a live picture. And you see that sometimes you need to put a central line beside of an interscalene catheter. So imagine the nurse on the normal ward is mixing this up, is putting the IV thing on an interscalene catheter and let it be parenteral nutrition, or what's even worse is putting the local anesthetics to the central line. So this is very clear that with the simple changement to NRFit, you really can prevent anesthesia-related death or paraplegia or other things. And we know this is necessary. The English, they have made it mandatory from the start of 25. There has been national patient safety alert. So it will be mandatory in next year, at the beginning of next year in the UK. I'm still waiting for something like that in Germany, and I would strongly support it and wish for that. And I was one of the first 3 hospitals in North Rhine-Westphalia in Germany to change to NRFit. And with industrial partnership, we successfully changed it in 2 weeks, and we had no major adverse events. So it's not rocket science to change to NRFit. It's recommended in literature. This is a very good paper by Topor and colleagues about best practices for safety and quality in peripheral regional anesthesia. And they emphasize that atypical presentation of LAST is not uncommon. It's not always easy to detect, and that NRFit connectors are recommended wherever available. So this is a clear statement. Why is LAST still a problem? And why may blocks still fail despite ultrasound? Another provocative question, because ultrasound led to much lower volumes of local anesthetics. I, in my residency, learned interscalene blocks with 30 ml. Some people used 40, and now I use personally 5 ml. Why is it still possible that we have LAST? Because, for example, aspiration during injection is a false sense of security. If you have veins and you put a probe on them, the veins are collapsed and you cannot see it. You will not aspirate. And so the only safe thing is to see how you get a lake of local anesthetics to visualize where your local anesthetic is going. This is the only safe way. And catheters, if you put catheters, they may dislocate. They may dislocate to ineffective, away from the targeted structure, okay, then the patient has pain, but they may also dislocate to dangerous into a vessel. This has been very, very often described in literature for central catheters, for neuraxial catheters, that this may also happen in peripheral regional anesthesia. Depending on the type of catheter, the tip may be at a totally different place than where the needle tip was seen. And so there is a nice technique to use power Doppler or color Doppler energy and to put micro-bolus into the catheter to see where the catheter tip is. Failure of blocks, you have to check it. There was a nice paper also by the group of Hygiene at 3 a.m. Do you know where a catheter tip is? No, we do not know. And a dislocated catheter remains a dislocated catheter, no matter how many boli you give. What's very frequent to dislocate is the interscalene, the trigonum femorale, and the adductor channel catheters. And if you test uncritically by topping up boli, this becomes very dangerous because you get all the things you don't want to have: phrenic paresis, recurrence paresis, Horner syndrome, weakness of quadriceps. And if you give many boli, you get a risk of LAST. And if you give many boli and have no success, you will lose the trust of your patient and of your surgeon. If you use the power Doppler micro-bolus of less than 0.5 ml, they are reasonable, they are nice, they are great to see the tip of the catheter, and this is a rational decision and not tactical actionism. I hope that the video will run. I will show you here. This is how you put micro-bolus of 0.2, 0.3, 0.5 into the catheter, and you see exactly, thanks to power Doppler energy, where the catheter tip is, in this case, at the site of the interscalene plexus. So this was just to show you that. These are the needles which you can use for it. They're very well fitted, these new catheters. Another reason why blocks may still fail is we are still learning anatomy. We know a lot of things by now about regional anesthesia, and I had to read a lot of things for this webinar and for other things. But what we still don't know exactly is what's the difference between dermatomes, myotomes, and osteotomes. Just think about it. I won't go into the details. Just always have that in mind, and don't say it's not possible that he has that pain. It is possible, because what you can test on your skin is not always correlating to what the patient feels in his muscles or in his bones. So if you want to implement regional anesthesia in your hospital, you need communication, science, and teamwork. For patient safety, we have to convince the surgeons. I know that very often we have to argue with the surgeons because of regional anesthesia, but if we really want to implement the structures and the bundles and the procedures, then we have to convince the surgeon. And what's helping us are the prospect guidelines that are existing for a lot of procedures, because prospect guidelines are very high quality recommendations, very high quality evidence and science, and very often there are also surgeons in the committees who wrote it. So before you implement a new block, inform the surgeon. If there's a risk of nerve injury, perhaps you have to open a diagnostic window. If you think of radial nerve and humerus fracture, for example, it is, for example, also possible to apply a block post-operatively in these cases where the surgeon is afraid. Clearly distinguish between anesthesia and analgesia. You can do analgesia without a motor block by reducing the concentration of LA, so your surgeon can still test the patient and the patient can still move. Be careful at the lower limb because of ERA's concepts and early motor mobilization. Think of motor sparing blocks. Include always the physiotherapist in a multimodal concept if you do a new block, and always announce the presence of nerve blocks during the surgical team time out in UR. We talked about team time out. Tell your surgeon, I did a block there and there, so the surgeon will not worry after the patient is awake and something is still blocked. And of course, go with the time. Nowadays, motor sparing blocks are the holy grail. It's about mobilization, it's about ERAs, so we need long-lasting motor-sparing blocks with low concentration and normally without catheters. We don't do nervus femoralis block anymore, femoral nerve block. We do it sometimes for emergency in the emergency room, that's fine, but the patients are at risk of falls because they have quadriceps weakness, so it's not for ERAs concepts, it's only for bedridden patients. And so use modern motor-sparing alternatives like the PAJUNK block for the hip, like the distal trigonum femoral or proximal adductor channel block for the knee. This is one of the most prominent and the most discussed and I think of the best developments of the last years, that we learned a lot of things, a lot of facts about these motor-sparing blocks, and they are working very, very well. What are you using? Ropivacaine, some adjuncts like dexamethasone, like dexmedetomidine, or liposomal bupivacaine. We will come back to liposomal bupivacaine. What is important is that if you want to do contemporary blocks, you need contemporary equipment. For example, you don't want to have a quadriceps palsy for hip fracture. So you are doing a nice PAJUNK block. But if you're using a bunch of local anesthetic, a gallon of local anesthetic, normally more than 20 ml in literature, or if you are too superficial, or if you're not below the psoas tendon, then the local anesthetic is flowing up. You see it nicely in the picture I have on the slide, and you have a retrograde femoral block. You can have that easier. So it's very, very important that you are deep enough, that you are steep enough. But if you want to do deep and steep blocks, you need an echogenic needle because you touch the boundaries of physics, and it doesn't work without a specialized ultrasound enhancing needle. You need that for modern blocks like the PAJUNK block. A special topic, a lot of discussions in the last time in Germany, because we have a minister of health who wants to do nearly every operation in outpatient surgery, in day surgery, to spare costs. What's about regional anesthesia in outpatient or day surgery? Well, first of all, we have the problem that by political will, at least in Germany, but it's the same thing in the United States, we will do outpatient surgery for minor surgery, but for very painful surgery, like shoulder surgery, like foot surgery, like open hernia repair. This is painful. And catheters are, of course, difficult in outpatients. They may dislocate, they may get misused, there may be infection, they may have last and nobody notices. Nevertheless, the low-tech pumps that are on the market, they are very safe nowadays because you cannot really destroy them, not by normal items. You really have to use very strong violence to destroy them, and there's no programming errors. You have to program them. They work at a fixed rate of 5 ml, for example, and so it's a little bit safer if you want to do catheters for day surgery outpatients. The question that we have to ask nowadays is, what about the single-use material, about sustainability and so on? But normally, single shot is preferred in outpatients. And does the analgesia last long enough? That's the questions. In upper limb and in trunk blocks, I would say it should last as long as possible. Because we want to avoid nocturnal rebound pain, we have to give multimodal analgesia with known opioids. And the question is, do we have to do more or less regional anesthesia in outpatient surgery? I'd say we should do more because it provides better analgesia and has less side effects than most of the non-opioids, and of course, less than the opioids. Then the question is, do we want to use potent opioids in outpatient surgery? Everybody who has visited the United States in the last years has seen what happens there, and a big part of the opioid crisis in the States is iatrogenic, is thanks to things like that, giving opioids to outpatients after operations. So in the upper limb and in the trunk blocks, I'm quite sure that can be the solution. In the lower limb, we have the problem of motor weakness, and we also have for every block the problem of limited safeguard mechanisms. So the patients may fall, they may not notice a compartment syndrome, they may have the risk of a mechanical or thermic injury. There are risks, but there are also risks if you use a lot of ibuprofen, for example. But especially for the lower limb, you have, again, to discuss it with your surgeon. Communication. If you do regional anesthesia for day surgery, then implement standards, implement checklists, implement an emergency phone number that the patient can call 24/7, rock around the clock. You have to give to the patients a handout with informations, and you have to call the patients the following day or to have them come to you for a neuro check on the following day. And of course, you should do a careful patient selection. Not every patient is fitted for regional anesthesia in day surgery. Think about dementia, think about alcoholism and things like that. You should do a careful patient selection. What about single shot blocks and rebound pain? This is also very, very interesting topic, and yes, popping up in literature more and more. We can use adjuvants. Clonidine is safe, yes. It is probably less effective than dexamethasone, and you have a high risk of hypotension. Dexmedetomycin is nice, but still very expensive. And the best data we have for dexamethasone. And no matter if you give it systemically or locally, I heard a lecture recently that locally 4 milligrams equals 8 milligrams systemically. I didn't read the paper, it was just in the lecture. I noticed that we know that it doesn't make a big difference if you give it IV or to the nerve. Keep in mind that all local anesthetics are neurotoxic if you use high concentration. So you can reduce the concentration by adjuvants and you can reduce the risk for the patient. Adding opioids, yes, for neuraxial regional anesthesia, we have data. For peripheral regional anesthesia, there's no sufficient data at all. Probably it's not useful. And for everything else, there are lots of trials and no evidence of benefits. And please do not use adrenaline as an adjunct because you have a risk the ischemia, you risk the ischemia of nerves. It has been clearly proven that adding adrenaline to nerve blocks increases the risk of ischemia and increases the risk of permanent nerve injury, PNI. Let's go back to the liposomal bupivacaine. Well, we have sufficient data that it's not a magic bullet. We don't use it in my hospital. I know that in Belgium it is used a lot, and they have quite convincing studies, but these are meta-analyses, these are reviews, and they found that liposomal bupivacaine is not a magic bullet and that does not have a real advantage, a clinical relevant advantage over, let's say, ropivacaine. So I use ropivacaine, but this is my opinion, my expert opinion, because I have this evidence. If you have good experience with liposomal bupivacaine, keep on using. What about nerve injuries? Yeah, it's very rare. Yeah, very rare. But if it happens, it's a catastrophe. Passenger nerve symptoms, perioperative nerve symptoms, PONS, is up to 15%. That's away next day, no problem. Transient reversible symptoms up to a week, it's 1 to 3%. Up to a week, it's gone. You have to know that because you have to tell your worried patient and you have to tell your worried surgeon. Neurological deficits up to 2 months, it's still rarer, 0.2%. And it has a very, very good prognosis. But there are the rare catastrophes where it lasts longer than 1 year. And if it lasts longer than 1 year, then it's a permanent nerve injury, and then prognosis is very bad. Then it will probably never go away again. And one of the problems of quality management, I'm talking this, the talk I'm giving to you is nothing else than quality management in regional anesthesia. The problem with quality management, if you have a very, very rare complication, you have to do a lot of effort and a lot of money and a lot of time to make a rare complication even rarer. But keep in mind that it's a catastrophic complication. We are talking about permanent nerve injury where the patient has some paralysis or something like that. So for the patient who has it, it's catastrophe, and for the surgeon also. But do not always blame the regional anesthesia because there are patient-associated risk factors, surgery-associated risk factors, or they have forgot the translation, I'm sorry for that, and regional anesthesia-associated risk factors. And again, what I said at the first slide, sonography, ultrasound per se did not reduce the incidence of permanent nerve injury. We know that ultrasound per se did not change anything about permanent nerve injury. And regional anesthesia is not always to blame, but you know that the anesthesiologists are there for the surgeons to have somebody to blame. That's our role and our destination. But you see, anesthesia factors are even the narrowest list, the shortest list. But if you have been with your needle somewhere else to a nerve injury, you will have to prove that it was not your needle. And sometimes that may be very, very difficult. So please think of the simple things to avoid permanent nerve injury. Do not aim directly at the nerve. Restrict the number of needle manipulations. Restrict the needle-nerve contacts. Stay lateral to the nerve. So let's say, in plain English, do not poke around the nerve. Circumferential spread is not mandatory for successful blocks. We have clear evidence for that. And think of dose-dependent neurotoxicity of local anesthetics. If you just want to do analgesia and not anesthesia, you do not need 0.75% ropivacaine, then you're fine with 0.2%. So in the last years, there has been the resurrection of the nerve stimulation for dual guidance. When I was a resident, I learned to find nerves with nerve stimulation, with electrical nerve stimulation. Now I learned to avoid nerves by electrical nerve stimulation. That's what we call dual guidance, because we know that ultrasound alone was not the magic bullet. We thought about how to improve patient safety, and one good idea was that we should combine ultrasound and nerve stimulation, not to find the nerves, not to get closer to the nerves, but to stay far away from the nerves. And this is the recommendation to withdraw and reposition the needle if a motor response occurs below 0.5 milliamperes. So stimulation is used to avoid nerves. We call it a protective stimulation. And there are a lot of good articles. I put you some here on the slide, but it's not the magic bullet either. It's not absolute safety. The threshold of actual intraneural needle position was in studies between 0.2 and 1.7 milliampere. So you have to combine the different techniques. You cannot say, I have this technique, now I'm safe, or my patient is safe. You have to combine, like in so many things in medicine, as we learned in the last 15 years, in many things in medicine, you have to do a bundle approach and combine things to get more safety and to get less complications. Because if you are intra or extraneural, if you see here the picture of a sciatic nerve, for example, what is the epineuroium? What is the perineuroium? Yeah, the paraneurium, perhaps you can see it. But the difference between the perineuroium and the epineuroium, you will never be able to see that with the current ultrasound machine. The current ultrasound technology is unable to distinguish this safely if you have a deep block and you're not superficial at the skin nerves. So this is important to keep in mind, that ultrasound has its limits. And this was a very good ESRA newsletter. And, you know, in America, things always have a big forensic implication. It's about a lot of money if there is a damage to the patient, if there's a permanent nerve injury. We talk about of hundreds and thousands of dollars. So it's very important that the American Society gave this newsletter and they said ultrasound and electronic nerve stimulation are complementary. They are not against each other, but they're complementary. So please use them both to prevent some nerve damage. And for sure, if you have a motor response at 0.2 milliampere, it's not millivolt, it's milliampere, you are intraneural, of course. And the question is, what they are telling us here, to talk to the patient, to have real-time feedback, to be safe. Yes, but we all agree probably that some patients who have dementia or things like that, they will profit from regional anesthesia. Probably they are the people who profit the most from regional anesthesia instead of general anesthesia, but they will not give you useful answers. So yes, real-time feedback from the patient is nice, if the patient is able to provide it, but it's not safety. So yes, we should combine these nerve stimulators. I showed you an elder model and a newer model. And so you can do dual guidance with the things I showed you, 0.1 milliampere and 0.1 milliseconds. It has a high specificity, but it has a low sensitivity because the motor response can be missing despite intraneural position. And again, NISORA has a very, very nice sheet of tips which you should use if you want to be, or if you want to increase the safety of your patients. We have gone one step further. We have now triple guidance. This is also a nice picture by NISORA, and we can monitor the injection pressure. Because if you are inside the nerve, especially if you're inside the perineurium, there's absolutely no space. Perineurium cannot expand. So we will have a high pressure because perineurium is very, very, it's like a very strong fascia and it cannot expand and you cannot open it up. So we'll have a high pressure, and it has been defined as an opening pressure of less than 15 psi, pound per square inch. If you want to inject yourself without assistance, like I showed you on the slide before, what we do a lot, it's helpful. But there has been a nice trial that even experienced anesthesiologists do not have the syringe feel to detect high opening pressure. You cannot feel, no matter how experienced you are, you cannot feel if you have 10, 15, or 20 psi. So you need some tools provided by industry. And these tools are these nerve guards. They are existing from different companies. And these nerve guards, they block your injection if the pressure is higher than 15 psi. So we talk nowadays about triple nerve protection for maximum safety. We combine ultrasound, we combine nerve stimulator, and we combine opening pressure. And I myself use opening pressure for every nerve block in my clinic, but I do not use it for fascia blocks. Because in fascia blocks, sometimes you need a higher opening pressure. I know that NISORA is telling this differently. They also recommend for you using it for fascia blocks. I personally do not use it for fascia blocks. I don't think the data is convincing, but I use it for every nerve block by now. And this is a great, it was great that industry was able to provide us with that. Here's a selection of literature. So you see there is a lot of literature about it's from the review I wrote for East European Journal. Triple guidance has a lot of literature. This is just for fun here. The Americans developed some tool to inject without help and under pressure. It was called Saphira. I think it's not on the European market anymore. But they had a pressure control of bigger than 20 psi, which according to the recent literature is too much. And we only had cost analysis for the United States, not for Europe. But what I want to focus on, what I want to tell you is that the lack of qualified staff we're experiencing in many, many countries in Europe, this will lead to ingenious inventions in the future. I'm quite sure that there will be ingenious inventions in the future because we have a lack of staff in nearly every country in Europe. We changed the topic again. We are going on our tour de force to another topic. Do we need ultrasound for neural axial regional anesthesia? Also there, these are German publications. They were the first ones in Europe in 2001, so it's not quite new. That neuraxial regional anesthesia can be improved and the safety can be improved by using ultrasound. And if you ask me if there's evidence that ultrasound and regional anesthesia is useful, yes. I don't want to read all that to you. We don't have time for 2 hours, but this is a nice review by Yu et al. And they just sampled all the studies till 2020 that showed that ultrasound is useful in regional anesthesia because you improve safety. How do you improve safety? It's because you increase the success rate at the first attempt. And we know that multiple attempts are clearly associated with a higher risk of complications. The number of skin punctures increases the risk of infection. The number of contacts to the bone increases the risk of bleeding, the risk of hematoma, and so on and so on. So ultrasound is able to identify the midline, to identify the intervertebral level, to identify the proper needle insertion point, and especially what I feel very safe with, we can measure the depth of the epidural space or the posterior complex to the skin. So we know how far we have to go with our epidural needle before it becomes risky, before we get close to the epidural space. And this is something I like very much. I do that every time because I feel safer with that. what is not clear now, or at the moment, it's clear with the studies I show you, but there are some ongoing trials, and I hope they will be published till we meet again in Prague for the ESRA Congress. At the moment, the evidence is that there was one well-made trial that compared ultrasound planning of your puncture with online ultrasound guidance, like you're doing it for peripheral blocks. For peripheral blocks, we're used to having the probe and the needle seeing and puncturing. And here I just talked about planning before, seeing how far you have to go, where's the best insertion point, and so on. And they compared the two techniques, and they said that at the moment, it's easier and better to plan by ultrasound, but not to do online guidance by ultrasound. There may be a big discussion about that, but that's the only really, really well-made trial about that I found at the moment. And I'm really, really interested in having new trials comparing these two techniques. At the moment, the ultrasound planning was safer, quicker, and more successful than the online ultrasound guidance. This is very interesting because we learn something completely different in peripheral nerve blocks, but these are neuraxial blocks. So the question is if we do not really need sono-enhanced TUI needles. Yeah, we know that all the needles are now sono-enhanced. You see that on that picture. Do we need that? Yes, I think we need it nevertheless, even if we are not doing online punctures for neuraxial, for epidurals, we're still doing erector spine blocks, and we're still doing paravertebral blocks. I mean, many of you probably, I hate paravertebral block, but many people are doing it. And especially for paravertebral block, which in my opinion is the most difficult block to see in ultrasound, it's very, very useful to have an ultrasound enhanced needle because you have a better visibility. So if you can have it in your country, if you can afford that, then it's absolutely useful to use that needle. Here, for example, you're seeing the picture of erector spine block. This is the number 1. Or if for the paravertebral block, this is the number 2. And you see at number 2 how close the costotransverse ligament and the pleura are to each other. We're talking about 3 millimeters or something like that. So I'm very happy to have an ultrasound enhanced needle for that if I have that high risk. So we're getting to the complications. How can we manage our complications? If we're talking about patient safety and developments, we have also to be aware of our complications and to manage them, not to call for help from surgeons, something like that, but what we're doing, we have to manage the complications. And feared complications of regional anesthesia can be very easily excluded or diagnosed by ultrasound. We talk about a regional anesthesia POCUS, point of care ultrasound for regional anesthesia complications. And it's, for example, very, very important for interscalene, supraclavicular, and infraclavicular blocks, because you know that you can do pneumothorax, you can do phrenic palsy, you can do vocal part palsy, you can do hematoma. You can see pneumothorax very easily by ultrasound. That's very, very, very easy to learn. And if you are able to do lung ultrasound, you can do it in 30 seconds. And I learned lung ultrasound in 3 months, and I'm trying to learn cardiac ultrasound for 15 years, and I still cannot do it. So this is easy to teach to your resident and to learn it, and pneumothorax is easy to see. Phrenic palsy is a little bit more difficult to see, but you can have a qualitative and a quantitative look at it. Vocal cord palsy, well, that's a little bit exotic. I will show you a film for that, but we're not doing that routinely. And hematoma is easy to detect in ultrasound. So my advice is, if you want to enhance safety of your patient, perform ultrasound before discharging the patient from the recovery room. If you do interscalene, supraclavicular, infraclavicular blocks, you have to do it before discharging them from the recovery room. I know that even in my clinic, only 50% of the cases we manage to do that. Not everybody is doing what the boss is telling them, but try to implement it. It's really a safety tool. It's not complicated. It's not difficult. And you get more used to ultrasound. You see the typical picture here in the film of lung sliding, and you see there is no pneumothorax. And you see the M mode, where you see what was called a seashore sign with the sky, the waves, and the sand. And you see also these vertical lines, which are the lung pulse. And if you see any of that, you can exclude ultrasound. You can exclude pneumothorax by ultrasound. So please try to implement that. You can have a look for ultrasound of diaphragmatic motility. You also can have a look at that film. You see it's moving very finely. Patient is breathing very well. Here nothing is moving. This patient, or is moving very, very little. This patient probably has phrenic palsy. The same thing goes if you do a M mode. Here, you see, don't see much movement in M mode. And in the last film I show you, we make a sniff test, and you see in the sniff test that there is a wave in the M mode, that it's moving. So these are things that you can easily teach and easily learn and implement it for patient safety. Sono for vocal cord palsy. Okay, this is a little bit exotic. If patient is hoarse after etaskalein especially, and you see the difference between the two films, left is working, right is not working. But I don't think this is very important to learn, because if you did etaskalein block and patient has hoarseness, he probably has a recurrence palsy. You have to explain to the patient it will go away as long as he has no dyspnea or tachypnea or panic attack, everything is fine. So last question, last topic, do we have to defend regional anesthesia? Yeah, sometimes we have to, I'm quite sure. There's the ongoing discussion about the infamous REGAIN trial. And I agree with the group of Admir Hadžić that the discussion about REGAIN trial is a little bit difficult, because REGAIN trial found there was no difference between general anesthesia and spinal anesthesia for hip fracture after 1 year. And the only significant thing they found was that there was even a little bit more pain in the spinal group, which was significant, but not clinically relevant, because we talked of a difference of NRS of 0.4. So that was quite ridiculous as finding. So the question we have to ask, if it is it really possible to change survival after 1 year in a group of 80-year-old frail patients by an anesthesiological technique that is lasting for 1 to 2 hours? And what's the difference between statistical significance and clinical relevance? And we should start to ask, and how well we perform anesthesia instead of comparing techniques. I'm deeply convinced of that. As long as we have not a standardized safety approach how to perform anesthesia, we can compare different techniques as long as we want, for years, for decades. But if everybody is doing like he did it always, or like she did it always, no, we should have safety standards for every spinal, for every peripheral block, for every general anesthesia, and which expertise is needed. Regional anesthesia techniques may be more depending on your personal skills than general anesthesia, than providing general anesthesia. This is clear, because it's a skill, it's a manual skill, so you have to train it. This is my comment to the REGAIN trial and the question if we have to defend regional anesthesia. And I will put you some questions answered and unanswered. Yes, regional anesthesia is opioid sparing. We all agree on that it's clear. But the question is it preventing delirium? There's no substantial or decisive evidence of the superior for single technique of regional anesthesia versus general anesthesia. This is pathophysiological thinking that we should be able to avoid delirium if we avoid opioids. But there are, I think, 37 other identified factors that we know that contribute to the delirium. So again, do your job as good as you can, but do not think that by your anesthesiological technique, you can change the whole outcome of the patient. You are just a piece of the puzzle. And the main trauma is done by the injury, by the trauma, by the surgeon, not by anesthesia. We know that in enhanced early recovery, so ERAs, multimodal pain therapy, and regional anesthesia provides better analgesia than using opioids. Regional anesthesia and non-opioids provides better pain therapy than using opioids. This has been shown by several trials, and I always put you a little bit of literature of that. The lecture will go online on YouTube, so you can always find it or take pictures however you want. And the question is, are the effects of our regional anesthesia local or systemic effects of local anesthetics? We know that local anesthetics have, to a certain degree, anti-inflammatory effects. And there was recently a trial, which made me a little bit sad, because a group showed that the analgesic effect of lidocaine IV was not inferior to epidurals in major abdominal surgery. I love doing thoracic epidurals, and I was quite, well, saddened by this trial. But there also, I think, that pain is not the only outcome parameter. It's also about sympathetic lysis and things like that. But this shows to us that using local anesthetics has also a systemic effect. And very, very serious authors and very, very famous experts are still discussing that the good evidence we have for some fascia blocks, like TAP block, may be also due to systemic effects, to systemic absorption. So the end is not near, the end is not far away. There are some questions that are answered and unanswered. We don't know that. What is answered? Some questions I think they're clearly answered, and you can go home with them and tell your administration and tell your surgeon and tell your superior these questions are answered. Especially the time efficiency of regional anesthesia is higher than of general anesthesia. Probably everybody of you in the audience has had the discussion with your surgeons. Oh, you want to do a block, it takes too much time. If you organize your hospital well, if you organize your OR well, and you implement block rooms, then the turnover is much faster. The induction in emergence will be much quicker than if you do general anesthesia alone with a lot of opioids. This has been clearly proven, and this is very, very nice literature by a German author, by the way, to show that. And if you have that discussion, I really recommend that to you. Regional anesthesia plus IV sedation is probably better with regard to CO2 footprint and sustainability compared to volatiles. You all know the discussion about desflurane and about N2O. So with regard to CO2 is much better. But we have also to ask a question to the industry. What can you do to lower the impact of plastics, of production, and of all the garbage? I think this is one of the big challenges for industry, to become better with all the garbage we produce by all the garbage which is surrounding our nice needles. I know the garbage is necessary to have sterile products, but this is an important question for the future. I told you that I want to have a glance at the crystal ball. And the last is that newly developed local anesthetics with quicker onset, like, for example, chloroprocaine, which is coming back and is becoming very popular, but also longer duration, which chloroprocaine does not provide, to prevent rebound pain with single shots. This should be the development of the industry too. We need better local anesthetics to prevent rebound pain. And I showed you that the liposomal bupivacaine is not the answer yet, but I think there will be new technologies. And of course, we will get better ultrasound. We have triple guidance, all that. But at the end of the day, the most important thing that we have to implement, that is the most important, is that we have structured teaching programs, that we have structured safety approaches, that we have a structured approach, a basic knowledge that every specialist of anesthesiology in every town in Germany, in every country in Europe should have. That's about hygiene, that's about defining basic blocks, what we're trying to do at the moment, and that's about structured teaching and safety problems, and trying to provide the best blocks to our patients, but especially the safest block to our patients. That's much more important than to invent yet another approach for hip fractures. And if you have any questions, you can also email me. And I hope to see many of you or some of you at the ESRA Congress in Prague. I will be there also at with PAJUNK, and so you can find me there if you want to discuss something in person. Thank you very much for your attendance and for your interest. And we stayed exactly inside the time limit, and so we are up for your questions. Thank you very much.
Thank you very much, Markus. It was very nice. I have some questions for you. I have a lot of compliments too.
Thank you.
So, okay, we have 3 or 4 questions. One question, for example, is from Muhammad. Any research on installing a camera with needles to see anatomy and structure?
Yeah, that's about, well, the question is going towards implementing artificial intelligence and these things. I don't know any serious studies about that, any blinded or let's say placebo-controlled studies, but that will be difficult to do because everybody is seeing if he has a camera or not. So we will probably not get the evidence. The most important point about that, in my opinion, is that at the moment we have good learning programs with artificial intelligence, for example, by PAJUNK, I have to mention it, but they are just admitted for teaching at the moment. They are not admitted for use at the patients. So I think we will have to wait for that, but it will surely come in the next 5 to 10 years. I'm quite sure about that.
Okay, thank you very much. Miriana asked, well, she said, very comprehensive approach, congratulations. What would you suggest for developing countries as step number 1 regarding patient safety? Introducing no lure lock connectors?
The two most important things for developing countries to improve patient safety, or the three most important things, I'd say. First of all, the communication structure. You really have to communicate like in the Airbus, yeah, like in a cockpit. So no fear between superiors and residents. Clear communication, no matter your level you have in your hospital. That's the first thing. Second thing is hygiene. I know this is a big problem in many Eastern European countries. I'm quite often there. And things like long fingernails or fingernails with color on them, or nice watches at your, or rings at your fingers, that's impossible. That has to go away. This is about hygiene. And I think the most important step that we can do, that industry can help us to do, is to offer NRFit in every European country. NRFit should be standard in every European country. I showed you why.
Thank you. And another question, Attila Bondar, does rebound pain exist, or it is the ordinary pain patient feels after LA wears off?
Well, I'm not a specialist in chronic pain and in pain physiology and pathophysiology. I would recommend to ask Professor Knežević from Chicago. He's the most expert I know in this field. I don't know about the things that really happen about neuronal plasticity and all these things discussed. Maybe it's the normal pain, but as we know very well, that I know about chronic pain, pain has a very important emotional component. And imagine you're a patient who was in the hospital, who is going home completely pain-free, not feeling anything, and then you get a massive pain because the block washes off, and you are alone at home at 3 o'clock in the morning. And I think then you have fear, you feel alone, and we know that these things enhance pain. So I cannot answer your question if it's really a different kind of pain, a different pathophysiological kind of pain. But I can tell you that is a patient who was pain-free and then experienced bad pain and is alone, he will feel this pain as worse because the psychological impact is very important. I hope this answers your question.
Thank you. And another question, thanks for the wonderful talk. We always go up for the insertion of nerve catheters. What is the general consensus regarding going up for spinal anesthetic?
For spinal, I'm not an expert in that either. I'm in a social media group of people who are performing thoracic segmental spinals. It's very popular in Italy. They have a big group doing that. In Germany, it's forbidden. Yeah, it's against the German guidelines and standards, so we're not performing that here. I cannot tell you any personal experience. I find it very fascinating and very interesting, but I don't have personal experience about going higher than the level of L2 with spinals. With epidurals, yes, my highest level of epidural I ever performed was T3, TH3, but for spinals in Germany at the moment, it's not possible. But as I have many European contacts, I'm following that approach. I find it quite interesting, probably quite difficult to learn it, but I cannot give you any advice about that.
Okay, thank you. Well, last question. This is a question from Ashaya. How do you convince an unscientific and stubborn surgeon that regional anesthesia takes more time than GA?
Yeah, it's an ongoing discussion. Of course, I have to discuss that with every surgeon in my clinic too. And funnily, it's always the same surgeons you have to discuss it with. There are some they understand it at a first or second approach, and there are some who need 25 approaches. It's the same everywhere. You can be quicker with regional anesthesia if you have what I call a block room or a holding area. Yeah, so you have to organize your OR in a way that you do not have to perform it sequentially, but you can do it while the other operation is still ongoing. And of course, this is a problem of staffing. If you do not have enough staff, be it doctors, be it nurses, or if you do not have enough experienced superiors who can supervise the blocks or provide the blocks themselves or teach the blocks, then it's impossible. Then you will lose time, of course. And then the surgeons are right if they're arguing. Nevertheless, if you compare, for example, spinal to general anesthesia, you will always be quicker because perhaps you take 3 minutes more for performing the spinal at the beginning, but your emergence is much quicker. Patient is awake and you can drive out immediately. Yeah. But if we talk about peripheral nerve block catheters and things like that, you really have to organize the OR in a way, and that needs rooms, and that needs money, and that needs stuff. I agree to that may be a problem for some countries, or if you have, for example, today I arrived and 4 people were missing that should have been there, then I have a problem to be quick, because then I'm a normal anesthesiologist in the OR. And I saw some other questions popping up. There was a question.
The 2 last questions. I have a question. What is your opinion on performing regional anesthesia for a patient who is under general anesthesia? What is your opinion on performing regional anesthesia for a patient that is under general anesthesia?
Yeah.
What you suggest doing regional anesthesia before general anesthesia, for example, in the case of a scalene block?
It depends on the patient and on the block. We do fascia blocks like tap blocks. We always do in general anesthesia on the sleeping patient because it's impossible to damage one single nerve in a tap block. Yeah, putting 60 ml of local anesthetics between fascia and an awake patient is not nice to the patient. That will cause pain. So we're doing the fascia blocks, the erector spine block. I don't do it that much. We do it for spine surgery. I don't like it for thoracic and abdominal. That would be another lecture. There's new evidence that it probably does not work for abdominal and thoracic. Erector spine, I do awake. All the other fascia blocks, we do asleep. Or we do, for example, a fascia iliaca block in the awake patient because it's an emergency. Patient is arriving in the emergency room, has massive pain, and we perform a fascia iliaca block. But abdominal wall blocks, we perform in the sleeping patient. So the question is about nerve blocks. And I showed you the slide, the recommendation by the American Society that we should communicate to the patient. But I also told you there are many patients who have no communication. And in a dementia patient who will not stay quiet, who will move all the time, and he will not give useful answers anyway, I also perform the nerve blocks in a sleeping patient. In Germany, it is still the standard that we should not do it in the sleeping patient. But this opinion is changing. I'm part of the scientific committee of German Society for Regional Anesthesia, and there are always big discussions about that question. And there are more and more people who are saying we can also perform this as safe in the sleeping patient if we use ultrasound, nerve stimulator, and pressure control. And so this question is still unresolved at the moment. The official German position is do it in the awake patient, except some fascia blocks, but the official position is changing, and I know many people doing it also at the sleeping patient, because if you have an incompliant patient who is moving all the time, it might be much safer to put your interscalene in a sleeping patient than having the needle close to all these structures with a patient which is moving around with its head. So I really make it dependent on the patient and on the setting.
And there is another question, just to clarify, by Naga. Would you wear a surgical gown while performing spinal anesthetics?
No, surgical, I would wear for every single shot, we wear gloves, we wear mouth-nose cover, yeah, like in COVID. I don't have to wear a head cover because I don't have hair. but in the OR I have to wear it anyway. And we are using short probe covers and sterile jelly. Yeah. The surgical gown is only necessary at the moment that you put catheters in. And there is absolutely no data on that. It's just an analogy that we draw from the data we have from putting central lines. We know for a long time that for central lines, we have to wear a surgical gown because the Seldinger is always poking around and touching you somewhere. And we fear the same for catheters. So the German standard or the West European standard is to say for single shots, we don't need a gown. We just need gloves and mouth-nose cover. But as soon as you put a catheter, like an epidural or like an interscalene catheter, then you wear a surgical gown. That's our rules. But every country has its own rules. You can find them of the British. It's free online. You can find the German rules. It's free online. You can find all that just by Googling. And it's a little bit different in different countries. But I think it's a quite reasonable idea how we're doing it, because I'm also a specialist in hospital hygiene. So I can a little bit compare the recommendations with other recommendations in other fields.
Thank you very much. Is there any contraindication to give SA to children below 5 years after giving general anesthesia like ketamine to make them cooperative for SA?
What do you want to give to them? What was the question? I did not get it.
Is there any contraindication to give SA to children below 5 years after giving GA, like ketamine, to make them cooperative for SA?
For spinal anesthesia, the sedation before spinal anesthesia. Well, it's some more than 10 years ago that I did spinal for newborns and babies, and we never did that under sedation because this is a very vulnerable population, which at very low doses of midazolam or ketamine can develop respiratory problems because of central respiratory drive. So for the newborns, we never did it. For bigger children, I would absolutely agree to do it in light sedation. Why not? It's the same as for the dementia patients. It's much safer if the patient is quiet. If you say, let's say, a 5-year-old, 6-year-old, and he's a little bit sedated, it will be probably easier. But I never performed spinal in children of that age. We did it for the newborns, and for the bigger children, we did caudal anesthesia as pain therapy, as analgesia, and caudal was always performed under general anesthesia or under sedation with, for example, dexmedetomidine. So yes, I would do that to have a cooperative child, which will not have a trauma afterwards.
Thank you very much. The last question, ropivacaine has intrinsic vasoconstrictor properties. Because of that, contraindicated in e.g. penile block or in the hand. Is this still valid? I'm asking because some of our surgeons state that they do not care anymore about that.
Yes, that's a very good question. I don't know any literature about that. There was at the beginning of ropivacaine that we had these concerns. First of all, for a digit, I would not use a long-lasting local anesthetic. I would probably use some quick-acting like ropivacaine or lidocaine. For penile block, it's an interesting question because we're talking about outpatients, we're talking about rebound pain and so on. But all the penile blocks I used to do when I was still doing urological children anesthesia were done by bupivacaine. At that time, it was quite easy because ropivacaine was in bigger vials and it was much more expensive and we didn't need that much. So we used bupivacaine, and the amount used is very, very low, so that the toxic difference between bupivacaine and ropivacaine did not matter for that question. And so I don't have experience with that. I will look for that. It's a very interesting question. I never read anything about that in the last 5 years. I have to ask some colleagues and to Google it a little bit to use it to look in Medline. I cannot answer that question. But if you feel unsafe, unsure, then I recommend using bupivacaine because there are 15, 20 years of experience that it's safe. But I read another question popping up a moment ago, why the prospect guidelines do not recommend catheters for pain therapy at the lower limb. At the lower limb, it's everything in prospect guidelines is about ERAs, basically. And for example, if you look at the recommendations for knee surgery, they clearly state that the best pain therapy is a catheter to the femoral nerve and to the sciatic nerve, but it's not recommended anymore because the patient will stay in bed for days, and that's not what we want. So prospect guidelines don't have to focus the best pain therapy, but they have to focus of the best general concept. And I think this is the approach we should have. And this is the approach where we anesthesiologists have also to learn something from the surgeons, that we should have a common approach, a bundle approach for the patient. And this is why I like all these prospect guidelines so much. I do not stick to all of them in my clinic, but if you really think about it, if you want to give a lecture, if you want to improve in your thinking about regional anesthesia or combining techniques, prospect guidelines, it's great. And of course, I know that I recommended several things that are not available in all the countries that were listening, like pressure control and so on. So this is also a call to the industry that they should make it available for the beginning, at least in all European countries. And I'm talking a lot to important people in PAJUNK, and I know that they're doing the best and trying to produce, and it will come. I'm quite sure it will come. Yeah.
Well, thank you very much for this nice presentation. Thank you very much to all of you to be with us this evening. And as Markus told, if you have any question, you can write to him. You see his email in the presentation, I think. Maybe.
Yeah, it was of the last slide of the presentation. So at last, when it comes to YouTube, you will find it back if you didn't take a photo now.
Have a nice evening, all of you. And thank you very much again for your presence.
Thank you. Bye-bye.
Bye-bye.